Shedding light on the complexities of health insurance and how it might be improved is one of the major reasons we created this channel. One of these complexities, cost sharing, and whether the way we use it is truly effective, is the topic of this week's Healthcare Triage. Much of the care provided in the United States is unnecessary or too expensive. Cost sharing is one way to try and push patients to be more thoughtful consumers of medical care. The blunt way we use it, however, often does more harm than good. Cost sharing is a blanket term for things like deductibles, copayments, and coinsurance. If patients are spending more out of pocket, their own money, they might think harder about whether care is worth it. One aspect of cost sharing in the United States that seems to make little sense, the notion of making it start over every year. Because of the way deductibles work, you pay them in the early months of the year, when things like the flu, and more recently, of course, COVID-19, are hitting. Since few people have met their deductible yet in the first few months, many will think twice about getting care at this time of year, right when the medical community most wants them to. Recognizing this, most insurers waived COVID-related cost sharing, though they are now considering reinstating it. Craig Garthwaite, director of the healthcare program at the Kellogg School of Management at Northwestern, says the biggest problem is that we don't discuss often enough what we're trying to accomplish. Quoting him, "There are two main reasons to consider cost sharing to be efficient. First, we might dissuade excess use of care, and second, we might move people across products to more cost-effective options. Otherwise, we're just decreasing the benefits of insurance." There's plenty of evidence in the amount of excess care. A study in PLOS One in 2017 asked doctors across the country how much care they thought people received that wasn't necessary. They reported that more than 20% of it wasn't. They thought that more than 10% of procedures, more than 20% of prescriptions, and about a quarter of tests weren't needed. A review of the literature published in JAMA in 2019 estimated that overtreatment or low-value care was responsible for $75 to $100 billion in waste a year. Of course, none of these things happen without a doctor's permission. Maybe we need patience to help in saying no. But it turns out that patients aren't very good at differentiating between necessary and unnecessary care. This isn't entirely their fault. If there aren't enough in-network specialists available, for instance, all the monetary incentives in the world can't make patients choose more wisely. Further, some care is clearly necessary. When expert panels deem something worthy of universal screening, for instance, it seems odd, not to mention counterproductive, to then put up barriers to obtaining it. Doctors don't want patients to second-guess the decision to get these screenings. We want everyone to do it. That was one of the main reasons that, as part of the Affordable Care Act, all screening with an A or B rating from the United States Preventive Services Task Force will be free without cost sharing. When it's deemed necessary for everyone, all barriers are removed. In many other facets of necessary care, though, the U.S. system isn't nearly as thoughtful. When people have asthma, for instance, and they're told they need a preventive steroid inhaler, that care's not optional. Doctors are not looking to have anyone question whether it's worth their money versus an insurance company's money. We want them to get and use the inhaler. The same holds true for many chronic conditions. People with high blood pressure must take their medication. Likewise, people with sickle cell disease, ulcerative colitis, and of course, cancer. When cost sharing is imposed for these diseases, the evidence suggests it leads fewer people to take their drugs, which leads to worse outcomes. In no disease is this clearer and more prevalent than diabetes. People with insulin-dependent diabetes, especially type 1 diabetes, must take their medication often many times a day, or they risk serious complications or even death in a very short period. This is where the second reason to use cost sharing comes into play. Perhaps there are cost-effective options for insulin. In that case, making sure one of them is available for low or no cost seems like a good idea. As things are set up now, when we look for care, there are usually almost no options available with low or no cost sharing. Everything costs money out of pocket, no matter which insulin you choose. Alternatively, the system could recognize that some diseases or conditions need more care, not less. For these cases, cost sharing can be eliminated or significantly reduced. In France, people with 32 specific chronic illnesses, making up 13% of the population, are exempt for co-payments for treatments for those diseases. In England, cost sharing is minimal, but even so, it's waived for people with cancer and other long-term conditions. In Germany, those with chronic conditions have their cost sharing capped at half the level of others. In these countries, the percentage of people 55 and over who skip doses of drugs is much lower than in the United States. People often skip doses because of the cost. One idea will be to change the types of cost sharing to be more strategic. Deductibles, for example, make much less sense than co-payments or coinsurance. Deductibles just try to make people second-guess their spending no matter what it's on. A better model might target people who choose high-cost options, increasing their cost sharing. Under a reference pricing system, for instance, which we've talked about in the past, insurers commit to pay the full cost for some lower cost but high-quality care, and patients must pay the difference if they decide to go to providers that cost more. Quoting Garth Wade again, reference pricing is smarter cost sharing because it puts the pressure not on the use of the service, but on the choice of a high-cost facility. In this way, it is less likely to decrease necessary care while still controlling costs. Cost sharing isn't inherently bad, but right now it doesn't appear to have a clear purpose. We seem to be getting all the harm without reaping much benefit. Hey, did you enjoy this episode? You might enjoy this previous episode on cost sharing pitfalls. We'd appreciate it if you'd like the video down below, subscribe to the channel, and consider going to patreon.com/healthcaretriage, where you can help support the show even during a global pandemic. We'd like to especially thank our research associates, James Glasgow and Joe Sevitz, and of course, our Surgeon Admiral Sam.